of to help our wounded, ill, and injured and their families work through the challenges that they're having. And ideally, those three are doing things like doing town halls together. So one of those three ought to be able to field the issue if the unit chain of command can't address it. There are some unique, as I learned as I was just reviewing my notes, there are some unique situations. Somebody reminded me today that there are some unique situations, the joint bases specifically. So who is filling that role for the garrison commander when it's not a joint base that the Army is the lead service? So I know we want to get to questions from the audience and the and also from those that are listening in. But again, I do want to thank these two great Army families, and frankly want to thank all the spouses for everything you do and every day you do it. And in closing, I just want to remember for everyone a part of a quotation from Abraham Lincoln that goes in part, "To care for him who shall have borne the battle." And I'd just like to emphasize to everyone that our Army is committed to doing everything we can to take care of our wounded, ill, and injured and their families, near term, mid-term, and long term. So thanks very much.
We're going to collect the white card, so if you've got questions, please raise them.
Okay, we've got our first question from Fort Hood, and the question is, since PTSD affects so many, are there plans to not only train medical professionals but spouses as well, so that they know and understand what to look for before it occurs and becomes more traumatic for their family? Maybe there could be an app for the smartphones to address some of these issues too.
Okay.
You're the PhD.
So. I think absolutely that is the goal, and I think we need to increase, again, our network of support so that it's not just one program providing education for spouses. So we have Melissa's program that actually does that. It provides information for spouses about what they need to know, not just about the service member's injury or illness, but also about how to talk with teachers. And you want to talk about that?
Yeah, we, through Family of a Vet, one of the things that our founder discovered when her husband came home with a brain injury and PTSD was the information that's out there. She was doing like hundreds of us are. We're going home from an appointment with a diagnosis without anything in hand. No one is giving you a brochure. I will tell you that my first actual printout in 6 years came from the VA in Palo Alto, California this spring, that actually said, what is a TBI? And it's taken 6 years to get a piece of paper that I haven't had to look up myself. And so what's being done through Family of a Vet is it's people like myself writing the article, saying this is what's going on at home, this is what I did, maybe I reacted poorly, maybe I reacted well, but it's all okay. We're learning together. We have a packet for legal help, we have a packet for FRGs that's available with education. You can download it, it's free. It's got a PowerPoint with it. You can use it at your meetings to inform families of the things that might be coming. Because honestly, I'd heard of PTSD when he was gone, but I never had any more information than that until he came back, and then it was all research done on my own. Just trying to get that information into people's hands. And again, saying, we're not professionals, we're not making a diagnosis, but look into these things. Print something out, take it into the doctor's office and say, hey, tell me about this. Does this apply to us or not, and why? And if you don't get the answer that you like, this is one of the things Sean hates when I say, but don't be afraid to keep asking questions. Don't be afraid to say, I don't agree with you, we need to keep going. He'll admit now that it's gotten him where he is and that he's pretty happy about that, but in the beginning he was very hesitant. And what I worry about is these young families. I have a couple that I've been working with for the past 2 months. They are 24 and 25 with a 2-year-old and a 3-year-old, and he has a severe TBI and severe PTSD. And look at their lifespan ahead of them. That's the next 70 years of their life. those people don't always speak up and say, excuse me, but I don't agree with you, or ask for a second opinion, because they've learned that this is the way we do things. And we're trying to just break down some of those walls and say it's okay.
3 quick points, if I might, so thanks to both of you for fielding that so I could think for a second. Three quick points. So one, our Army and the NFL are partnering and doing some TBI, concussive head injury, a partnership, research, get awareness. In fact, several former NFL players were here yesterday meeting with the Army leadership, had lunch with a great young man, former NFL player, and he gets it. He understands the warrior ethos, and he understands why our soldiers sometimes are reluctant to come forward, and that is part of the problem, is everybody tells you they're okay. Again, your Army Community Services, while they're not the professionals, they can get you connected to the right people. So there are a number of places on post to turn to if you have questions about PTSD. Not only the hospital, but social work services, family advocacy, Army Community Services, and then again the Master Resiliency Training as we continue to evolve continue to evolve comprehensive soldier and family fitness and make it more family friendly. These are the types of feedback that frankly we need so that we work together to help identify the things that are on the minds of family members. And the last thing I would say is that, under the direction of the Vice Chief of Staff of the Army, there's a Health of the Force triad. The Surgeon General, my boss, General Ferreter, and his other hat is the Assistant Chief of Staff of Installation Management and the Army G1. And these are the types of issues that we're trying to look at and get quick wins and identify and cut through some of the bureaucracy and get to what those out in the field need the most. Thanks.
Okay, our next question is broad, and it relates to FRG leaders. Are there any tips that you can provide for FRG leaders to help assist families with wounded soldiers?
All right, I'll take this one. In our case, when Greg got injured, we picked up and left. But prior to that, our brigade had a number of service members who were killed in action and wounded in action. And so when the FRG leaders were trying to provide support to those families, again, it was a very individual, case-by-case basis. Some families needed some help with children. Some families needed assistance with communication as far as language barriers. It really just depends on a case-by-case basis. I can't tell you how many times people want me to write down a booklet or a manual on how to do FRG. Like, well, you need to know your people, and I can't write you a manual for that. So really knowing your people and what their needs are and what their specific needs are in an instance is what you need to adapt to. And that's what we're also very good at, is adapting to the needs of people at the time.
Great, thank you, ma'am. Next question. What is being done to educate professionals dealing with domestic violence about differences when a service member has PTS or PTSD, especially in remote areas, outside of going through the chain of concern or chain of command? Is there a place for a family member to get help when the service member is denying he or she has an issue?
Well, I'll take part of that question. So several places that the family member can turn to. First and foremost, chain of command, chain of concern. If it's not being addressed adequately through the chain of command, then through the family advocacy program manager. And if you're not at an installation, or if you happen to be geographically dispersed, you can access the family advocacy program through Army OneSource. There's also an Army OneSource service locator that goes on your smartphone. I think we have it for smartphones and Blackberries now. And if you have the self-locating device on, you just put in your location and put family advocacy, and it'll show you where the nearest service provider is. It'll give you telephone numbers, and so if there's a certain installation family advocacy office you want to contact, you can contact them through Army One Source.
If I can just address, maybe this is more on the prevention side, but and not necessarily about reporting domestic violence, but if you have a sense that your relationships are unstable and in trouble to that level, there are service providers that do relationship-based work that really help families and couples improve their skills, enhance their skills, get back on the same page, and communicate about things that would hopefully then avoid it getting to the level of violence. So I know that a lot of our wounded, ill, and injured families do suffer from a lot of anger towards each other. The spouse may be angry that he or she's having to do more. The service member may be angry or frustrated because he or she can't do more. And although it may not necessarily reach the level of domestic violence, it definitely puts our families in these precarious spots. And so my sort of push is not just mental health. Mental health is great, and we want people to go get individual services, but get relationship-based services that will work with you across your relationships.
And if I can just pile on Dr. Mogul's answer there. So you're absolutely right. I mean, prevention and education is where we really need to be focusing a lot of our effort. And so I know Chaplain Rutherford was in here earlier today. He talked a lot about strong bonds. There's also strong bonds for single soldiers that are in relationships but not married. So marriage enrichment, relationship building. And then the new parent support program also offers a way to teach parenting skills and coping mechanisms and build resiliency. And it's geared towards new parents, but you know, some of us more seasoned parents could probably use some of the new parent support education. So there are some programs out there at our installations to help on the prevention and education and prevention side, as well as the intervention and treatment.
Okay. Great, thank you, sir. The next question is for Dr. Mogul from UCLA. What is the link between the UCLA Focus program you mentioned and the Army's resiliency training?
That's a good question. It's not linked. I believe both of our programs are very familiar and aware of each other. And certainly part of both of the programs would be to enhance, you know, the access to services that are available to families. And so in that sense, we try to stay very aware of what they're doing and how they're doing it and how they can support families. Focus is a family model, and my understanding of the Army's resiliency training, while there is a family component, that it also has a large implementation that cuts across, you know, the service member side as well. And we don't do that. We really focus on the entire family, and that's however you define family, whether that's a biological child, whether it's a boyfriend or a girlfriend, whether it's your own parents who maybe are providing some care for your kids, or however, a neighbor, maybe a best friend. So we really work in that relationship model, and we leave the more individual work to others.
And we are very aware of the Focus program, and so there are a lot of similarities, and there are some things that the Focus program covers that maybe our comprehensive soldier and family fitness does not necessarily address. One of the big gaps that we noticed when we were looking at Focus and some of the capabilities it brought was the attention it paid on children. And so that's clearly an area where we think there's great value in the Focus program. And so we continue to look at, you know, as General Ferriter mentioned in one of the earlier forums, there's a lot of different programs out there. And so we're trying to say, okay, we're not saying program good, program something less than good, but what are the capabilities that it brings? What's the outcomes? Is it evidence-based? And how do we knit together really the best of breed to build readiness and resiliency in our soldiers, our families, and our units? And so we'll continue to work down this path with our partners on the Army staff and in OSD and others. So.
Okay. Our next question is, thank you for taking a heart-wrenching topic and turning it into very heartwarming stories. It always amazes me how much support the Army provides its soldiers and families when they know it's needed. In lieu of the drawdown of troops, is the initiative to keep wounded warriors in the Army going to be decreased or reevaluated? I'll take a stab at it first. As the CG of Warrior Transition Command and an Assistant Surgeon General for Warrior Care and Transition, I can tell you that the Army leadership and our DoD leadership has been very clear that this is a sacred obligation. This is an enduring program. Warrior Transition Command is conducting analysis at this time. We're calling it a strategic posture review, and we're doing it in conjunction with our Army staff, MedCom, and other Army agency partners to really evaluate what the future looks like. And I don't want to get out in front of any analysis because it's a difficult problem to analyze, but we know that we're going to have a need for these types of services and warrior transition units for a very long time to come. Right now, it looks like it could be at least 6,000 soldiers who are wounded, injured, or ill that require this type of service for the many years to come, for the next 4 or 5 years. Warrior transition units are here to stay. The Warrior Transition Command will continue to not only take care of the soldiers that are assigned currently, but make sure that the programs are being put in place to address challenges as they emerge so that we stay left of the boom. And I'll offer it up to other panel members if they have anything to add. Okay, next question. This is for anyone. PTSD is starting to be called PTSI, parentheses, injury. If so, is it an extension of TBI, and are they related? Dr. Mogul, you have
Again, doctor would be the key indicator that you should take this question.
You guys are really calling me to the carpet here. Without a doubt, there are overlapping, very confusing symptom clusters for both diagnoses, and it is really hard to piece apart, even for our folks who do it every day. It's just, they're similar. There's the reactivity, the hyperarousal. There's also, there's frustration. There's ability to kind of dysregulate in a moment's notice, and all of that can be part of either one of these. And I think that's what makes it really, really confusing for not only the people trying to make a clean diagnosis, but for those trying to serve these service members and their families. And one of the ways that we approach it is not to necessarily, well, a diagnosis is good and it's helpful in a lot of ways, but we try to focus more on what are the signs and symptoms and behaviors that are affecting the family, because that's actually where we can intervene more. So regardless of if you think it might be TBI with PTSD, or it might just be PTSD or just TBI, what's going on? What does it look like day to day, and how is it affecting you? So for intervention, we can go from there. So that's not really a straight answer to the question, but that's how we approach it.
Thanks, Doctor. We appreciate the response. Our next question, we have time for 2 more. The next question is for Melissa. Does Family of a Vet have packets for potential employers, and how can we make contact with them?
We don't have packets for employers yet. It's on our list. Right now we have a packet for FRGs and leaders for different military organizations. We have a packet for teachers and parents on PTSD and TBI that you can print off and fill out and take to the school to help facilitate that conversation. We have a packet for legal issues that they may be having, PTSD in the legal system. We have a community packet that's available online right now for people who are non-military, who maybe want to get involved, want to get their organization involved, or individuals. Upcoming, we have a church packet. We have a packet for employers. We have an emergency packet that we're working on. And we're always willing to take any new suggestions. It just takes a little time and manpower. And we always remind people that every one of us working on this has someone at home who has some type of a limitation or a disability. And so we're living the life. It takes us a little bit longer to get things done, but yes, it's in the works. So.
Thank you very much. And we have one more question. This is a PTSD-related question. PTSD seems to always be associated with a combat mission or incident. Is there anything we're doing to look into the effects of multiple deployments, increasing stress levels in service members to the point of psychological dysfunction? Factors such as returning to unemployment status, transitioning back to normal lifestyle, integration into society, all of this could be affected as well.
One of the things we know, not just with combat-related PTSD, but PTSD in general, is there is kind of the wear and tear that depletes our resources slowly over time. And so what happens is it might not just be one event that puts us in a tailspin or puts us into like a full-blown PTSD reaction, but it's the slow wear and tear that wears us down so our resources are depleted, and then when this event happens, it sort of pushes us into that. And so I actually don't know what the Army is doing to look into that, but I do know that is what happens, and like I said, it happens outside of the Army too. This is what happens to human beings. It's that cascade effect that you might have one incident that goes awry. It might be a illness of your child, but then from that you're spending the days and nights in the hospital, and after that you're losing your job, and after that, so it's this build-up effect that really can do the wear and tear on families.
And that's one of the many reasons why we're constantly looking at the comprehensive soldier and family fitness and the master resiliency training. It's to build that resiliency to handle all the things that Dr. Mogul just discussed. And so I don't know what the medical research that the Surgeon General or others in the department are doing, so I'll stay away from that. I didn't even stay at a Holiday Inn Express last night. So, but we are trying to. It is a very complex situation, the nexus of all these things, and so this whole notion of TBI versus MTBI versus PTSD, a lot of the indicators are similar. And so again, we think that building resilience in folks and being able, not only the soldier but the family too, will help address a lot of the issues as we move forward.
Can I add one more thing? Sorry. So I think related to that, if we can really work with all of our systems of care to not make PTSD a bad word. It is scary, and if a family gets that diagnosis, it's going to be scary. But if we can help them to see that you'll get through it, there are services, there is light at the end of the tunnel. Of course, we have to do a better job of getting those services to the families. But if I think everyone here is committed to doing that. So if we can sort of break down that barrier in the fear of it, people are more likely to talk, and they're more likely to utilize their resilient skills that they learned about communication and sharing how they're feeling and doing and being aware of their own emotions and share that with those around them. So I think we're getting there.
Okay, thank you. I've been told that was the last question, but there was one more that was an easy answer, so I'll just put that in there. What's the difference between wounded and injured? You'll notice that we all mentioned wounded, injured, and ill soldiers, and the bottom line is we're caring for all our soldiers regardless of the source of their injury or their wound, and wound refers to combat wounds, and injuries are accident or non-combat related, but they're treated with the same level of priority and care. And that's important for us in Warrior Transition Command. At this time, I'm told the Surgeon General is available.
Yeah, a
Ma'am?
lifeline.
Ma'am, go ahead.
Thanks,
Be like
ma'am.
a commercial. It's an announcement by your Surgeon General. Now, I didn't want to miss an opportunity with the research that you had mentioned. Part of what we looked at, there's a lot of research that has been ongoing. One of the things that we found, it's not so much the multiple deployments, it's the bog dwell time. It's the amount of time that family members and soldiers have on the ground in between deployments that allow for reintegration back into the family, back into the unit. And so that's actually part of what was changed over the last couple years, is that we realized you at least need 2 years between deployments so that you can start reintegrating into your family and being able to tap into some of the services that are there. And then the other thing with PTSD, it is, there's a lot of talk in the American Psychiatric Association and across the Army on whether or not you should drop the D for disease and whether it should be injury. Really what we want to make sure that people understand is that a majority that go in and get the services, and even those that get the diagnoses of PTSD, 80% of those go on, they are healed, and they live very productive lives. And so what I'd ask is that we don't get wrapped around so much whether or not it's a disease or it's an illness, but it's an experience or a traumatic event that we want to make sure that people go forward to seek care to focus on psychological health and their well-being. So thank you. Thanks.
Thanks, ma'am.
Thank you very much, ma'am. We appreciate you coming in and helping us answer the question. We still have 17 questions that are unanswered. I will work with Patty to make sure that we somehow connect with those of you who are out there waiting on answers. I want to thank the members of the panel. I appreciate your great presentations and the responses to the questions, and appreciate all you do for our soldiers and our warriors and what you've done for your families. Thank you, sir, as well. Thank you very much.